First of all, let me thank you all for being here. Our goal here has been as a company to be able to provide medical information and help with diagnostic and medical testing to be able to support clinicians who are working with chronic immune-mediated neuropsychiatric disorders. So let me start here by giving at least a little disclaimer. This webinar has been made for informational purposes only. And it's not intended to be medical or healthcare advice for any individual medical problem, but we would encourage you to reach out to your medical professional healthcare provider with any questions. However, the goal here is to share with you an understanding of what we have identified and worked on through research, development, clinical studies about how the immune system, the brain, and infections are all tied together. So what we're going to cover today is, can infections trigger neuropsychiatric disorders? And why is it that certain infections can trigger these immune-mediated neuropsychiatric disorders? You might be familiar with PANDAS and PANS, and the acronym we'll talk about a little bit more and what it means. And then another area that seems to be more prevalent as we grow and we see more infections from tick-borne diseases is neurologic Lyme. Of course, everybody is very familiar with COVID, but the aftermath of the long-term sequelae of long COVID is also a very common or a very similar type of syndrome. We're going to then delve into some of these case studies. And I'm going to maybe jump around and maybe skip a little bit because I want to make sure we touch on the topics and then be sure that you have time to ask questions. But our goal here is to be able to share with you how these biochemical targets are being attacked by our immune system that would result in diagnoses that would be not responsive to typical standard of care, such as psychotropic medication, or in many cases might even get worse. So let me tell you just a little bit of history about the company. We started 20 years ago, 20 years of research under Dr. Madeline Cunningham's lab in strep infections in Sydenham, Korea. And from that, the last 14 years, we have been developing and working on the clinical validation and then providing testing. The way that it started really was a clinical study with children who had OCD and tics and presented with neuropsychiatric disorders, but they all proceeded with a strep infection. And so what had happened was patients had gotten tested, treated and recovered in this clinical study, but it ended. And calls continued for over a year wanting to be included in this study. And one of the parents quoted said, "We watch hopelessly as our dear children lose chunks of their childhood to something so few currently understand." So there are over 800 million individuals who suffer from different types of neurologic, psychiatric, and behavioral disorders. You may recognize many of these different diagnoses, and maybe some of you or your children or those you know might be afflicted by these. The thing that's interesting about all of this really is that these are diagnosed by symptoms, and the standard of care for these is treatment with psychotropic drugs. And because they are symptom categorized through a constellation of various types of symptoms, there are about 20% to 60% of these patients are deemed treatment resistant, which means that they have been tried and put on multiple medications and to no improvement. Now, often in the cases of patients that are immune-mediated infection triggered, the standard of care medications actually can make an individual symptoms worse. So why is this still a problem? As I mentioned, that these disorders are diagnosed by symptoms. And so there could be a multiple constellation of reasons why an individual would be exhibiting different types of neurologic, psychiatric, and behavioral disorders. And so, for instance, if you look at Tourette's syndrome, Tourette's, by definition, is the manifestation of motor or vocal tics for more than 12 months. This has really no relationship to what the underlying etiology or the underlying root is, because there could be more than one, and there is maybe potentially multiple reasons for the causes of or the manifestation of Tourette's. So if you look at autoimmune disorders, we also find that cancer and autoimmune has a biological relationship. So I won't go into this, but this is a piece of information that actually, in some cases, helped identify these different types of disorders, which were formerly known as paraneoplastic. And so the immune system is constantly what we call having tolerance, meaning it's looking for what's us and what is not us. And what happens in autoimmune immune-mediated disorders, the immune system recognizes self as being foreign and begins attacking it. Whereas in cancer, the immune system doesn't recognize foreign, but it thinks foreign is self. And they become a dysfunction of the immune system, and there are responses to immunomodulatory therapy. So let me just share with you one study here. This is a patient who got schizophrenia. He got cancer and then got cured. This was a psychiatrist in Japan who diagnosed a patient with paranoid schizophrenia. And after multiple psychotic drugs, the patients were deemed treatment resistant. And a year later, the patient developed acute myeloid leukemia and needed a bone marrow transplant. After this procedure, his schizophrenia seemingly vanished, and he's completely off all medications and shows no psychiatric symptoms. And the doctor said somehow the transplant cured his schizophrenia. So in a published medical journal, Frontiers in Psychiatry, what you can see here in this particular graph is this scale here, a positive and negative syndrome scale. Once the bone marrow transplant was given, the patient actually recovered and began functioning in a normal manner. And this global assessment of functioning, which was very low, improved almost to 100% here. So this doesn't mean that cancer and people who have neuropsychiatric disorders will get cancer. It's actually the understanding that the immune system is the common root. So let's go a little bit more here into this, and we're going to skip a couple of these because this is actually more detailed and less time than we have. I actually have 144 slides in this particular one. Inflammation and immune dysfunction have more significant effect on chronic disorders than we previously understood. So chronic diseases have been known to be linked to inflammation. And what we're talking about is neurologic diseases. We mentioned autoimmune diseases, but the company is also working on autoimmune cardiovascular and autoimmune Alzheimer's. So I'm going to skip through a couple of slides here, as I mentioned, because due to time. This is our innate immunity, and our innate immunity and our adaptive immunity is what brings in the autoantibodies. And as a result of it, when these autoantibodies are developed, they actually begin to target different parts of the brain. There's also a recognition that Alzheimer's is now believed to be an autoimmune disease. And it's believed that infection and inflammation is one of the main triggers of Alzheimer's, and that this can occur many years, potentially decades, prior to actually the onset. And so again, this brings us back to the immune system's role and as a culprit in this. So again, I'm going to skip through here many of these slides, but what I want to share is that the immune system and inflammatory mediated disorders are not new. So when our antibodies attack our joints, we call that rheumatoid arthritis. When our antibodies and our immune system attacks the pancreas or the insulin cells, we call that diabetes type 1. When our antibodies or immune system, our T cells attack the myelin sheath around our nerves, we call that multiple sclerosis. But what happens when antibodies or immune system attacks the brain? Often we will call that many different things. It can be ADD, ADHD, schizophrenia, others, PANS, PANDAS, parts of autism. But again, they're not all caused by the same underlying root reason. And this is why it's important to identify what the root cause is and then treat the root. So again, let me move in here to what the healthcare problem is. So in our studies, what we have found, the typical patient journey, in which a patient will actually course through 5 to 15 medical providers prior to actually getting a proper diagnosis. You may relate to this if this is something that you're going through, or maybe some of your family or other members that your loved ones. We typically find that between 3 to 7 years, they're going through multiple trial and error medications, spending between 20,000 to over 100,000 in medical visits, doctor visits, and ineffective treatments. And so this is one of the reasons why we started the company, is to be able to help identify and learn to understand what is the underlying root and treat the root rather than treating the symptoms. Unfortunately, during this study, we've been looking at many of these patients have completed these questionnaires, but the heart-breaking comments that you can see here are a result of many of these different situations that our patients have gone through. Our goal is to be able to quickly identify what the underlying root is and not have patients go through this trial and error and multiple doctor visits. So again, let me jump through here. As I already mentioned, the standard of care for psychiatric medications. We actually have tested now today over 16,000 patients. 85% of them we find have one or more autoantibodies attacking neurotransmitters in the brain. And this is what we call our Autoimmune Brain Panel, which we're going to talk about a couple of case studies here in just a second. So we found that we can identify patients whose condition is due to an immune dysfunction and are responsive to immunotherapy. Well, let me run through a couple of other things here. And I apologize, I'm going to go through a few of these and skip several of these just in respective time here. The question now becomes, can infections really trigger neuropsychiatric disorders? This is a journal called JAMA Psychiatry, which is one of the premier journals. A study was published and completed in March of 2019 of over 1 million individuals. What they found that by following patients from birth to age 18, that if they were hospitalized for a severe infection, that the risk of developing a mental disorder increased by more than 80% for schizophrenia, autism, obsessive compulsive disorder, ADD, ADHD, and many, many others. So the question was, how could exposure to infections affect the brain and give rise to mental disorders? What they said was circulating autoantibodies that enter the brain via compromised blood-brain barrier bind to neurotransmitter receptors is a potential explanation, and that's been proposed in pandas and other mental disorders. So without getting into too much detail here, basically this is what we're looking at in the Autoimmune Brain Panel. We're looking, are there antibodies that are attacking specific neurotransmitters in the brain that are tied to these patients' symptoms? So how does that occur biologically? Well, everyone gets infections, and as a result, we all make antibodies to these infections. Well, in some individuals, and this is the key, some individuals, the antibodies that they make actually are made against a portion of the organism that's cross-reactive, meaning looks like or identical to a part of, let's say, a neurologic receptor or a nerve cell. And as a result of it, it then will be directed to interfere with the brain function through what we think of as friendly fire, and symptoms of neurologic, different types of neurologic symptoms will manifest. Patients will be placed on psychiatric meds, but as I mentioned, they become or known as treatment resistant. Whereas when patients are identified properly, they respond to immune modulators and anti-inflammatory agents with some very, very remarkable results. So again, let me run through a few of these different things here, and I'm going to skip a few of these. It's very common to see in literature that these terms, what we'll say autoimmune encephalopathy, encephalitis, neuroimmune disorders, are being published more and more, which means that our goal and hope is that medical science will begin to be seen in private practice and common practice. But at the moment, right now, it's something that most clinicians, physicians have not learned in medical school because these things have been evolving over time. So again, as I mentioned, the antibodies that cross the blood-brain barrier bind to these neurotransmitters and interfere with these various receptors in the brain. Again, let me move through a few of these. And again, you may have heard of one called NMDAR, autoantibody. This is actually Susanna Calahan, who wrote a book called Brain on Fire. And actually Hollywood made a movie of it. And what they found out was that she had antibodies against these specific brain receptors. Now, Celine Dion is another individual who has an autoantibody dysfunction where another neurologic receptor, she had made antibodies against what's called GAD65. And as a result of it, this is called stiff person syndrome, where you see muscle stiffness, spasms, and other neurologic conditions. And so there is a commonality in that the immune system is triggered by an infection. This infection triggers the immune system in that individual to be misdirected against targets in the brain, and as a result, manifest in various types of symptoms. So there's this complex interaction between the infections, the immune system, the brain, and the thing that ties it together is this genetic predisposition. Now, let me move on again. As I mentioned, I've got 144 slides here that we won't have time to go through. But two things must happen. So bacteria, infection, and the antibodies recognize what we call an epitope that's similar to another epitope in one of the nerve cells. And when that happens, you get this cross-reactive autoimmune binding. And so the blood-brain barrier, which is breached, and we won't go through too much detail in this, but it is also very similar to the barrier in our gut, which often you'll see patients having gut dysbiosis, what's called leaky gut syndrome, or the acronym or the description of leaky gut, leaky brain. So we believe and see that PANDAS is a medical model. Many of you might have come in contact or seen or heard of, or maybe even have a family member who may have been identified or diagnosed with PANDAS. PANDAS is pediatric autoimmune neuropsychiatric disorder associated with a strep infection. And what we find is that it was described back in the 90s by Dr. Swedo post a strep infection and worked with Dr. Madeline Cunningham, our co-founder. And you can see here that this is a patient drawing prior to the observed tics or the triggering of that, and the patient, the child, after observed tics, the loss of his fine motor movement. PANDAS, though, is estimated that 1 out of 150 to 200 children may have PANDAS. And the criteria for PANS is very similar, but there are some very strict criteria, such as abrupt onset and additional types of concurrent symptoms that occur with it. And in this case, it has to be a child. So if you're an adult, you can't have PANS and you can't have PANDAS. It doesn't mean, though, you can't have that same syndrome or a version of it. But interestingly, autoimmune neuropsychiatric disorders are not new, and these have been triggered by infection in the past, which is known as St. Vitus's dance or Sydenham chorea, and it's caused by group A streptococci. It is also one of the reasons that rheumatic fever occurs, because the antibodies are attacking the heart, and about 30% of those with rheumatic fever get Sydenham chorea. So let me just give you a little bit of nomenclature here. Pandas and other microbes and environmental targets can comprise infectious triggers or non-infectious triggers, which is why the term PANS came along. PANS, as you can see, doesn't refer to strep, but it just refers to the acute onset of neuropsychiatric syndromes. So PANS includes pandas, and it includes other microbes and other types of triggers. But if you're an adult, you really can't have any of these. So ANDL, or an adult autoimmune neuropsychiatric disorder associated with Lyme, many of these other acronyms we won't go into, but basically we're seeing these as an autoimmune encephalopathy, what's called a basal ganglia encephalitis, but really what you really need to want to know is this is an immune dysfunction that results in neuropsychiatric and behavioral symptoms triggered by an infection. So I'm not going to go through the basal ganglia, but there's a very strong tie to the specific functions of it and how these antibodies correlate with it, and studies in mice that actually can show this. So long COVID is actually another manifestation of an infection-triggered autoimmune condition. However, the targets include the brain, the heart, the lungs, the blood vessels. And so the term post-acute sequelae of SARS-CoV-2 or PASC or long COVID has been given this nomenclature. The challenge, though, for clinicians and patients with these disorders is it's difficult to actually go through and find out what the underlying root cause is without some kind of external testing to show that these antibodies are present. So I'm going to briefly touch on why there are certain infections do this. And again, we'll kind of briefly go through some of these things, and I'm going to skip a few of these others. Strep is one of them, and strep has been very notorious, which is why PANDAS has the S on the end. It refers to strep. But as you can see, influenza, varicella, mycoplasma, Lyme, Babesia, Bartonella, Coxsackie virus continue to be very commonly associated with these different types of immune-mediated syndromes. I'm not going to have time to talk about molecular mimicry here, but suffice it to say that if you look at our immune system, it's actually been programmed to identify what's self and what's non-self. And again, I apologize that these aren't the summarized slides, but I hope you'll be able to join at another one when we'll have these a little bit more condensed. But this particular slide shows that the immune system is being trained to know what is you and what is not you. And in certain individuals, these escape the central tolerance and the peripheral tolerance. So again, we'll move through this. If you look at strep and why strep in particular, it's because of this particular part of the outside of the strep bacteria that looks very similar to a part of the brain, very similar to a part of the heart. And what happens in those cases is that it then begins to manifest. Influenza has done that. If you're very familiar with also narcolepsy, it's also an autoimmune condition that's related to influenza and other types of infections. Again, Lyme is another one, and I'm going to move through a couple of these so that we can get to the case studies. So basically summarizing this, autoimmunity occurs when there's a breakdown in our self and non-self discrimination. Some may have been told that they have maybe SNPs or mutations in the major histocompatibility complex, but basically this is friendly fire we think of in the wartime. And so molecular mimicry, which is why I named the company Moleculera Labs, is because we're looking at really this molecular mimicry that results in chronic disorders from infections that actually stimulate the immune system. So as we move into what really is this blood test that we're talking about, it's the reason is that precision medicine is very important to be able to get to a proper diagnosis. And therefore, people that have the same symptoms can be caused by underlying different causes or different roots. So there are 5 targets in this particular panel, and we're able to separate patients that are caused by immune-mediated underlying reasons, and those that are not will then respond to the psychiatric medications, where those that are immune mediated will respond to immune and anti-inflammatory and anti-infectives. So let me move over to a couple of case studies here and we can look through this. I'm going to save the publication here because that's something that we can send to you. But if you look at some of these case studies, this is an 8-year-old girl that had multiple neuropsychiatric symptoms: an abrupt onset, obsessive compulsive behavior, vocal tics, poor concentration, emotional ability, and many other issues. And we had tested her, and you can see the 5 different targets here. And she was positive for a lysoganglioside GM1 and positive for antitubulin. We run 5 because we don't know which ones would be representative to cause or be correlated yet with symptoms that patients may be diagnosed with. She had anxiety, OCD, and in this case, the ASO or strep titers and the anti-DNase B were normal. So this could be a challenge, and maybe people might think, well, you don't have a strep infection or don't have pandas, or it could be multiple other infections, but she had a significant history of 2 recent streptococcal infections and a history of ear infections, sinus infections, and other types of fever. And then she had positive for mycoplasma. And what you can see here is that there's been an underlying frequent infection in her life. So the good thing was she was caught early, and because of it, they just treated her with an antibiotic and rapid improvement in all of her symptoms. And she returned to baseline in 2 to 3 days of treatment. We tested her afterwards, and her lysoganglioside and tubulin returned to baseline. And so her immune system didn't get set in strong enough. But as time goes on, the immune system becomes stronger. And it might take a little bit more, including some of these other modalities that we'll talk about in order for a patient to improve. This is a 17-year-old young man who had also abrupt onset of OCD and other symptoms. This panel showed a positive, what we call our CAM kinase 2 assay. And I'll talk more a little bit about what that is and why that's important. But this particular young man had OCD, difficulty concentrating, sleep disturbances, many different symptoms, and also he didn't want to go to school, which by itself might not have been something too bad, but when patients become very disruptive or even violent, that's not usual. Panic disorders, emotional disorders, and also something that could complicate here was traumatic brain injury. The lab results showed that there was Coxsackie virus, parvovirus, herpes virus, hypogammaglobulinemia and MARCoNS, and a history of chronic sinusitis and frequent viral infections. Family history was interesting in that there was rheumatic fever in the family, therefore the potential for a predisposition, a genetic predisposition for an autoimmune condition. This patient improved with just NSAIDs and was treated with intravenous immunoglobulin. And you can see in this case, post-treatment, after the patient recovered, their CAM kinase returned to normal. So another girl, 16-year-old, severe OCD, tics, and restricted food intake. Now, sometimes this could be confused with anorexia. This restricted food intake in these cases typically are an obsessive compulsive disorder, meaning they are a fear of food contamination, a fear of choking, a fear of vomiting, rather than a body dysmorphism or a self-image issue. So as you can see, since 11, this individual had this food restrictive issue. But the sad thing is this was so bad that the parents had called the police 6 times during the course of this patient's condition. And you can see, again, in this case, the CAM kinase was elevated. We had a borderline tubulin and a borderline dopamine D1. Some symptoms are relapsing, remitting, and then various types of post-infectious diseases, positive Western blot for Lyme, elevated mycoplasma, Coxsackie titers. So family history showed they had some autoimmune disorders, which was another tip-off. Now, this patient was treated with plasmapheresis and IVIG with good symptom improvement, and they had this patient on low dose SSRIs for maintenance. And then after post-treatment testing, her CAM kinase returned into the normal range. I'm going to skip a couple of these others to get to the to the conclusions, but know that these are available. We have various types of information on the website, and then we've got some published studies. I'm going to talk about this one briefly. This is a publication by Dr. Bernstein at Cincinnati Children's Hospital. This was a severe case of a 15-year-old girl who had been diagnosed and treated for schizophrenia and psychosis and severe anxiety. And she was in and out of a treatment facility. They had called in Dr. Bernstein, who's an immunologist, and he was aware of the Autoimmune Brain Panel. She was tested, and all 5 of her dopamine D1, dopamine D2, lysoganglioside, and tubulin were positive. He treated her with 1 course of plasmapheresis, and the patient had complete resolution of her psychotic OCD and anxiety. He then weaned her off of olanzapine and resumed many of her normal activities within 2 weeks after plasmapheresis, and the response has been sustained. So this kind of gives you an idea of it's possible that many cases that are treatment resistant could actually be an underlying immune-mediated function. So there are more studies, and again, like I mentioned, these are available on our website. And this is a summary now of the targets in the autoimmune brain panel. We look at, does a patient have antibodies against dopamine D1? And when they do, we frequently see psychiatric symptoms, mood swings, depression, anxiety, irritability, etc. If a patient has antibodies against dopamine D2, frequently we could see some level of movement disorders, like choreiform movement. Maybe they might have been diagnosed with ADHD because they couldn't sit still, possibly Parkinson's. Antibodies directed against lysoganglioside GM1. Typically, they'll complain of joint connective tissue pain and other types of tics. We see this more frequently, tubulin autoantibodies, and patients then present with obsessive compulsive disorders, often around food phobia, clothing. Brain fog is another common complaint when we see anti-tubulin. And then when the patient is positive for CAM kinase activation, which is basically the antibodies are stimulating this particular enzyme in the brain that is tied into the sympathetic nervous system activation. So you'll see fight or flight behavior, anxiety, various types of sensitivities, easily startled, etc. And these are the 5 targets that we look for. Again, I'm going to move through this, but there's different frequencies of which we see these percentages. They're on our website. You can look and find them in the website. And CAM kinase is one of those that is emerging as an important one. So I'm going to move through the kinase, so we're not going to spend a lot of time on that. And let me get to stories here. So let me share with you, you can look at our website. We have literally dozens and dozens and now getting close to hundreds of patient stories. This is Grace, young girl who was diagnosed with a mental disorder at age 8. She was trying to kill herself. She ended up, the parents found out about us. We tested Grace. She was positive and treated successfully. Her mom sent us this picture of her recently back to normal life and on the cheer team. Adam, you can see Adam's story on our website. He was diagnosed with ADHD. They even thought he could have had autism, and they were thinking about putting him in an institution. They actually had moved a location close to us, found out about us. He was tested and positive, was treated successfully. Not too long ago, his mother sent us a picture of him running cross country. Same recovery as possible. He's 10,000 times better. She even sent us more recently a picture of him graduating, which is a handsome young man now. So, as I mentioned, there are some commonalities of patients that are positive for these testing. And they typically can be seen as treatment resistant to standard neuropsychiatric drugs, have multiple infections, and possibly Lyme, post-Lyme treatment, a family history of autoimmune disorders, maybe sudden or rapid onset of neuropsych symptoms, but they don't have to be sudden. But in order to be diagnosed with PANS or PANDAS, they do have to be a sudden onset. Same thing for obsessive compulsive disorder. Remembering the restrictive eating disorder is really an OCD, vocal or motor movements, depression, dilated pupils, relapsing remitting. And this is an important one. One of our pediatric neurologists who probably tested over 1,000 patients with our autoimmune brain panel. And she said that every single one of her patients, if you ask them, and you have to ask them, but ask them, that they will admit to dealing with suicidal ideation. And I think this is important because we do also know of and have worked with a few individuals or family who their child has taken their life through suicide. And so it is very important to be sure that there's an understanding of, is this an immune-mediated disorder, or is the patient improving, and is this something that could be treated with something different, meaning is it an immune dysfunction or is this not? So important as always to take a medical history that's thorough. So you should have a clinician, physician, someone who's very at least open and understanding to this type of a disorder, remembering that a family history of autoimmune disorders can be a trigger or one of the kind of tip-offs, eating disorders, obsessional fears, and what we call this choreiform movements, these piano playing finger movements. One of our clinicians says if you have them close their eyes, hold their hands out, and see if they start moving their fingers uncontrollably, this is what we know are called choreiform movements, dysgraphia, tics, mydriasis. And I mentioned some labs. Today we're talking about the Autoimmune Brain Panel and how this can help identify some of these different targets. There's lots of publications that are available, and we have them on our website, or if you're interested, we can have them sent to even your physician or clinician. So again, I'm going to kind of move through many of these things, but if there's interest in either ordering, testing, and the results process, this is what the process looks like. We require that a healthcare provider order the panel and be the individual, or at least one of the individuals, who will be responsible for taking care of the patient and treating. The blood will be sent overnight to us. The charge for the panel is $995. We must collect a $495 deposit up front. We are still a very small company, and although the costs don't cover currently our expenses, one of our goals here is to be able to help with insurance reimbursement, which we do bill for as a courtesy. It comes overnight to us, and we will test all 5 of those targets because they are all very important and very informative. And then it takes 2 to 3 weeks. It used to take 5 weeks, but we're down to 2 to 3, and our goal is to get it down below a couple of days. The results are then electronically submitted to the clinician, and then, as I mentioned, we will bill the patient's insurance. About half of them get some reimbursement. We also have some payment plans, but our goal is to help everyone who wants to be able to have be tested. And then the clinician physician gets online access, and we provide consultation to the clinician. So if you as a patient or a family member or someone are wanting to know how can you order it, well, you can't order it directly, but you can talk to your healthcare provider about ordering it. And there is a requisition that can be downloaded from our website, and that can be taken to your clinician, and or we can actually have an in-service. One of our nurses can provide an in-service to the medical center or the medical office. And then we're happy to be able to follow up with post results and post-treatment. So let them know that there's medical in-services available at no charge. And our goal here is to help people get well. I'm going to briefly just touch on, there are multiple treatments that are effective because we're really looking at 3 things. 1, treating an infection. This is an antibiotic paper that showed the treatment efficacy for Septinar, and then IVIG and plasma exchange. And there's some other studies on looking at IVIG. I don't want you to leave to think that these are the only treatments. These are the ones that have been published. These are things that people have published and that they have shown efficacy with immune modulators, anti-infectives, and anti-inflammatories. So the take-home message here is that first thing here is to rule out other causes and get a proper diagnosis. And then look at, are there multiple infections? As you saw, there can be. And then treat the inflammatory pathway and the inflammation, treat the immune dysfunction, and if needed, provide symptomatic relief. And we can boil this down to the 3 I's. We've got some infections, inflammation, and immune dysfunction, and these need to be treated. Sometimes during the treatment, if the patient's been ill for a long period of time, you can get things like metabolic dysfunction, gut dysbiosis, and as the treatments are being effective, you get Herxheimer reactions and die-offs from the infections. So it is important to work with a clinician who's familiar with what's going on so they can help navigate that process. So they fall into, as I mentioned, anti-infectives, anti-inflammatory, immune modulators, and temporary relief. So there are some journal articles from the Journal of Child and Adolescent Psychopharmacology. If your clinician is interested in, there's some very clear guidance from the PANDAS Physician Network. But for more information, you can reach out to our office. We have free resources, publications, videos, brochures, and we also can answer questions about blood drawing. What we don't do in particular is give medical advice to patients. We're happy to talk to your provider, give them medical information. But what we can do is if you're an individual or you have a child or someone interested, we can talk to you about the insurance coverage and the payment plans. And if you have medical health care, a provider who is interested in learning more, have them contact us at our medical relations at moleculera.com. So as I mentioned, those are supportive services. Briefly, we have this clinically available called our Autoimmune Brain Panel. We hope to, by next year, be launching what we'll call our Autoimmune Cardiovascular Panel, which will look at myocarditis, cardiomyopathy, and heart failure. And we're looking at the early markers for identifying Alzheimer's prior to symptoms. These, again, are focused on infection-mediated immune modulatory disorders. So getting to the root is very important, and I'm going to summarize this and then open for questions. Dr. Sidney Baker is one who's started or worked on the Defeat Autism Now, said if you're sitting on a TAC, treatment is not 2 Advil every 3 to 4 hours. Treatment for TAC sitting is TAC removal, meaning, as I've been sharing, we want to get to the root to treat the cause rather than the symptoms. And the second TAC law was if you're sitting on 2 TACs, removing one doesn't take away 50% of the symptoms, meaning that these complex conditions have multiple triggers, and therefore you have to address all of them. So if it's infection-mediated immune triggered, then you want to treat the infections, you want to treat the immune system, and you want to treat the inflammation. There are some references for various books and in some cases videos here, and they're available, and you can see those here and online. And so I'm going to pause here, but thank you. There are other groups that also are supportive online, the Pandas Network and many of these others, but we're also here to help, and our goal is to help change how medicine is practiced for those that are suffering from these immune-mediated inflammatory conditions. So, Amy, I'm going to pause here, see if we have any questions, and I thank you for your patience during this technical issue, and some of our slides got the wrong ones here, but it's more information than maybe you expected to hear, but the next time we'll have this in a more condensed version.
One question that we've had this evening is how do you know if a patient is appropriate for Cunningham panel or autoimmune brain panel testing?
Yeah, that's the kind of get to the point question. There are several things. One of them is, are they getting better on current treatment? And if the answer is no, are they treatment resistant to what thoughts of standard practice treatments? That's one indication, because it could be that this could be an immune-mediated condition. The second component is if you have noticed, you'll see this relapsing remitting syndrome, meaning it gets better sometimes, gets worse. And the third really, is there any often infections that have been associated with the syndrome? Sometimes there's not, sometimes you don't see this, but really the key is the lack of improvement in what might be known as standard of care, and actually sometimes they even get worse. So this is why we see patients going between 5 to 15 different providers, because they're looking for answers, and that particular provider who works in one specialty has tried everything they've done, but it's not improving. So those are some of the general conditions and considerations. But again, get to your healthcare provider and let them make that decision, but we're happy to help in any way we can.
And our second and final question this evening is, can the autoimmune brain panel be useful for adults?
Yes, actually, that's a very good question, because in the beginning, when we started, we were principally seeing pediatric patients. Today, about 50% of the patients that come for testing are adults. And we do see the similar patterns of elevated autoantibodies and similar responsiveness to immune modulators, anti-infectives, and anti-inflammatory agents. So the answer is yes. There might be some other caveats or nuances in adults, but in general, yes, the answer is yes.
Okay. Just a couple more questions. Are you finding that providers are open to learning about the panel?
We do find that many of them are, and then some of them are not. And again, this goes back to a lot of the information that's being generated and evolving is post their training in medical school. So those that are really open to learning and understanding, we find them to be very, very open and responsive. In fact, our staff, Amy and our other nurse, spend a lot of time with many of these clinicians helping with in-services. And so the goal is really to find one who is, if you don't have one that is responsive and interested or understanding, first try that and we can help by giving an in-service. If you still don't have much success there, we could help, because we have about 2,800 of them who have placed orders so far.
And our final question from our friend Gerardo in Mexico. We are from Mexico, and what type of doctor can help? And I'm anxious to share with him about our friend Dr. Morales.
Yes, yes. There are some good clinicians there, and Dr. Morales is in Mexico, and Puerto Vallarta, I think. Is that right? Yeah.
Mm-hmm.
And he has a really excellent clinic if you're interested. He also works with very chronic cases and very difficult cases. And so we can provide a referral to him also. So we do have individuals from literally different, over 50 countries who we have worked with, and we have partners in different countries. So it is something that is not isolated in the United States. Interestingly, I mean, we get patients from Ukraine, Poland, Belgium, London, UK, everywhere. And they're very similar in the symptoms. So it doesn't matter really the location. It really is something that I think is underappreciated and not fully recognized, but it is something that is treatable.
Can mild cases of PANDAS also be identified by the autoimmune brain panel?
Yes, and PANDAS is by definition a clinical diagnosis. So what you will see and know is that even though this will be an aid to that diagnosis, we find that it is important to find and have biological evidence to support the treatment change from standard of care. So the answer is yes. Now, of course, patients who have mild cases may be able to be treated as some kind of therapy to see if that might be effective or work. But when they're unsure and switching from standard of care to, let's say, any of these other modalities, it is helpful to have some biological evidence to say that there is some underlying immune modulatory or mediated effect.
Okay, Dr. Shimasaki, I believe that is all of our questions for this evening. And thank you again for a wonderful talk. Thank you all for participating with us this evening. Thank you for your patience. And by all means, let us know how we can be of help. Thank you.
I see one more here that says, how long before one sees results with IVIG treatments? And that's a really good question. Because as you know, intravenous immunoglobulin is basically accumulation of about 1,000 plus patients. And often patients will respond to IVIG. In some cases, it's believed it resets the immune system. Typically, it depends on one, has the patient been free from the infections? Because again, infections will stimulate the immune system. And then how long has the patient been ill? Some report of a single dose of IVIG being helpful. Others have seen where you have to have multiple doses over sustained periods of time. And some of this we believe has to do with the length of duration of how long the immune system has been in this state. So it depends, but the half-life of IVIG is identified as about 45 days. And typically what you'll see is some type of effect, during that period of time, if it is actually one of the reasons for that.
Thank you for catching that last question.
I think it just came in right at the end.
Okay. Well, all right. Again, thank you, Dr. Shimasaki. We look forward to seeing everyone again in the future.
Thank you, Amy, and thank you everyone for being here, and appreciate your patience as we work through some technical difficulties here, but know that we're here to help, and we look forward to helping you and or your clinician in the future.
Good night.
Good night.